So thank you and welcome everybody. And first thing I'll say is it was nice of City to give me I'll call it a demotion. I'm actually not a doctor, I'm a nurse. And have been doing project work with the renal agency now for probably close to 10 years. Originally started out, I guess, with some vascular access work, and then secondly joined the kidney care clinic when it got started, or kidney care committee when it got started with Monica. And then I guess the newest and latest committee is the hemodialysis committee, which is what I'm going to focus on today. So the hemodialysis committee was established in 2014, which if you kind of do the math on when all the other groups were started, it was the last group to get started. I think probably because it seemed a bit daunting, and I kind of understand now, looking back, why that thought was. The purpose of really getting it going was to develop a common approach and a framework for hemodialysis across BC. And I think if you remember from, I didn't do any of those fancy games because John was really supposed to be up here, that there's 13 in-center units and there's 27 community dialysis units throughout the province and geographically across the entire province. And each of them providing great care for many, many years, and now then coming together as a health authority and trying to do more standardization, and then finally coming together provincially. So it's been, we're still, I call ourselves still in the kind of, I guess we're past the infancy now, we're probably into the toddler and moving into the early teen years, but we still have a lot of work to do, but we've done a lot in the last few years, which is what I'll focus on today. The second thing is looking at evidence-based resources, and similar to the other committees, we've been furiously developing guidelines and protocols and some patient handouts. Supporting local implementation of provincial strategies and initiatives. So things like TB screening, which I'll talk a little bit more about, our kind of overall plan was done provincially, but it's really up to the individual health authorities to implement those plans locally. And so the role of our committee is really to have some discussion about that in terms of the hows and the whys and what are the barriers as we go forward with implementation, and really trying to, if there are barriers that we can attack at a provincial level, we try and do that, and otherwise it really is as a cheerleader and support for moving forward at a local level. Finally, and I think this is probably a more recent activity for us, but is really looking around research activities current in hemodialysis, including the evaluation of new and current therapies. And we have done a position paper or a literature review, I guess and called it Practice Considerations for HDF, and I'm sure we'll be moving more into this area as we move further into our teens and early 20 years. Who are we and how often do we meet? So we've got reps from all across BC and from all disciplines that participate in hemodialysis. We originally started out, I think Dr. Anderson was keen to sort of keep a small group that could kind of move forward and be nimble. We started out with about 15, and I think we're now up to 40. When I did the count, it was somewhere in the 40s on our committee. It doesn't sound as onerous as it is, but I think we quite quickly learned that people were actually wanting to join this committee, which you hate to turn someone down who wants to be on a committee. So we're actually quite pleased to have a broader membership. I think it kind of helps us to move forward. We do a lot of our work, like Monica was suggesting in the KCCs, we do a lot of the actual nitty-gritty work in working groups. So we come together by video conference every second month to work as a larger group, and then we usually plan one face-to-face meeting during the year. As we mentioned, John Antonson is our chair, who's a nephrologist in Vancouver Island and is a very passionate person about this topic and has been driving us along in a perfect direction. And then Yuri Melnick and myself provide the project support. We have some subcommittees, the technical committee, which apparently everybody really likes on our website, washing, cleaning and disinfecting the dialysis machines. Who would have known? They kind of detail all of the technical pieces for the hemodialysis group and then bring forward recommendations to the committee. There's a renal educators group that's been in existence for a long time. So once the hemodialysis committee formed, the renal educators group had a closer link with the hemodialysis committee, which I think has been helpful on both fronts. And lastly, the same position for the Vascular Access Educators Group has been going for a long time and is now under the umbrella of the Hemodialysis Committee. And we have working groups as we decide on new topics. So maybe I'll stop for a moment and ask those of you that are on the Hemodialysis Committee that are here today to stand up. Come on, 40 some odd people. Got a few. Great, and thank you to all of you for all of your work, and I think we're moving forward the way we need to. So I was going to focus on 3 different projects that we've been working on, and then the last slide is really just a compilation of some of the other ones that I'll go through more quickly. So the first one is because other places have best practices papers, we decided we needed one. That was for the community dialysis units. It was kind of one of our first efforts within the Hemodialysis Committee. I think there was a feeling at that time that there was lots of gains to be made by bringing a group together to focus on community dialysis units. A lot of the attention and time and talking in our committee, larger committee, had been around the in-center activities. So we established a fairly large working group again for CDU, and I'll talk about that shortly. The acuity scale is another thing that had been floating along in the background and had been used in varying degrees in different units across the province for several years in some cases and not at all in other cases. So we really put a push towards a province-wide implementation in the last couple of years. And thirdly, we'll talk a little bit about the TB screening program, which was a partnership with BCKD and also with the Peritoneal Dialysis Committee. So why did we do a best practices paper? I think we wanted to establish a common philosophy of care across the BC CDUs. And those of you that have been around, I think the 10+ years in dialysis, maybe even the 5+ years in dialysis, probably remember that when CDUs were first started, there was a whole different purpose for them, and it was really intended for patients that were pretty much independent or self-care, and that would be able to sort of foster that model and promote wellness. As time has emerged and patients have changed, and also I think the purposes of the CDU has also changed, we thought it was important to come together and acknowledge that there was a change that's still there for its original purpose, but it was now receiving and accepting patients that were higher needs and higher acuity, and we needed to acknowledge that, and it was all for the benefit of the patients. And so we have come up with a common philosophy of care, which is on the website, which you can read at your leisure. We wanted to maximize and optimize the utilization of CDUs. I think in general, there was a feeling that in the communities where there was not a CDU, it was easy to get people to go to CDUs so that they could stay in their home communities. Where there's a CDU and an in-center in the same community, it's a little more challenging because patients come to an in-center, they get comfortable in an in-center, and it's hard to move them on. So we had some discussion, and there's some work in our paper around strategies to try and encourage appropriate patients to use CDUs. Describe the types of services appropriate to be offered in CDUs. It was fairly variable all over the map in terms of what were the services being offered, and also to help patients stay in their home community for as long as possible. So the paper's on the website, and there's just a picture there for you of the table of contents to give you a sense of sort of what's in there, but encourage you, for those that are interested, to go to the website. And our real focus now is just continuing to implement the guideline and continuing to check back to make sure that we've got the right criteria, the right services. But we are hoping that we'll sort of push the boundaries in terms of who we can manage in CDUs. Second initiative I mentioned was the acuity scale, and several of you probably have heard about that for a long time. And I think what our approach this time was, and it was in agreement with, I remember a phone call with all the renal administrators soon before we had done an update to the scale, which had been done by the Renal Educators Group, and we had validated it. And then there was a phone call to talk about, well, how are we going to use it? How's this going to be useful? And so we agreed collectively as a renal administrators group and hemodialysis committee that we would use it province-wide, that we would pick a month in time twice a year, that we would all do the same assessment of our patients, And then that will give us, over time, some really useful data, both to use at a systems level, as well as we're hoping it will be used also as at a local level or at a HD unit level. And I think I understand that the renal administrators are meeting this afternoon to talk about the results of the first 3 data points that we have and how that might be able to be used for them in terms of practice decisions and administrative decisions. So I think it's great to see it being utilized and for all the purposes that are listed on the slide. There's a quick snap of what the tool looks like for those of you that aren't familiar. It's pretty simple. We've had many inquiries about it. As far as I know, it's kind of the first one around, and it's certainly the first one to be used in a systematic way in the way that we're using it now. So what's it showing? And there is a report that's been circulated that has more detail right down to the center level. But just to give you some, I think, interesting in recognizing these are point in time, and I think we'll get more stability with the numbers as time goes on and we have more points in time. We just recently ran it again in October 2018, so we don't have those results. But as you can see, I don't know if it's a surprise to you, not a surprise to you, but the acuity scores in the in-center units and the rural remote CDUs were some fairly consistently higher. Probably, as referred to before, the rural remote CDUs are probably keeping patients so that they can to be patient-centered, and so that when they can manage that, so that they don't need to go and move to another community to have their dialysis. Again, we're doing some further work just in terms of some of the definitions. We're looking where there's variability across the criteria to see if we can tighten up definitions, reduce any sort of subjective inter-rater reliability. But I think we're pretty confident in these numbers, given that the tool's been validated and being utilized now across the unit. So looking forward to getting further data and talking more about how to actually use the data in a meaningful way. I think we focus so far on really the tool itself, and I think it's now time to say, okay, these are the results of the tool. What do we do with what do we do with those, and how will that impact us? Third topic that I was going to talk quickly about is TB screening. As mentioned, this was a new initiative that actually came out of a pilot project that was done at VGH and St. Paul's, and that's what the little graph shows you. The number of active TB cases in an 8-year period at St. Paul's and VGH was, I think it was 8, if I remember the exact data point. And in 2013, after initiating screening and appropriate treatment for those patients that screened positive, it came down to 0 in 2013. So lots of work behind the scenes, and I think thanks to Dr. Levin for that, and work with BCCDC, we agreed that we would implement this for all new hemodialysis and peritoneal dialysis patients across the province. That started about 2 years ago, and I think it's gone really well. It took a lot of effort to get it up and running and get people understanding what the screening was all about and all the recs in promise and all those kind of things. But I think we've finished that piece of it now, and I think we're well underway to hopefully reducing or getting down to 0 in terms of TB screening incidence in hemodialysis population. So it consists of a new guideline, which is a really detailed guideline, and new tools. We used PROMIS as much as we could to try and make sure that all the data around screening resides in PROMIS, so that if a patient goes from one unit to another, the data is available to them. How are we doing with this? And this is a little bit old data, so I suspect it's actually even going to get better, but this was the cohort who initiated dialysis in the last 4 months of 2017. And you can see it varied a little bit across the units, and some of them were a little later getting started, which is why I think we're in the process of rerunning the data now. I think the data will actually be better. I think it's still really good, 80% screening in a brand new program. We'd only been going for about 9 months at that time. I thought we've done really well to get 80% of our patients screened. So what does that mean in terms of from the patient point of view? So on average, we start about 700 new patients on hemodialysis every year. We did this. We haven't actually got the outcome data. We're still working on getting that. So this is a theoretical concept, but I think is based in the literature and the results in the past. 80%, if our goal is 100, but at the moment we're getting 80% completing the screening. The preliminary data showed there was about 13% that would come up with a positive screen, so that brings it to 73% of the patients, and of those, about 70%, again, preliminary data, accepted treatment. So following those numbers through, that means that we have 50 less TB carriers each year in the dialysis population. So as new patients come on and continue to get screened and continue to get treated, our goal is to actually get down to 0 TB carriers in the population, in the hemodialysis population and peritoneal dialysis population. What are our other achievements? As a committee, we now have a way to address critical incidences as they come up. There was a recent one around machine contamination, and I think it worked very well, where the incident was brought to the hemodialysis committee. The committee was all involved at all health authority levels. The vendors were involved as needed. We came to a resolution, and we're sort of closing the books on that one now. So I think it was a really good example of a province-wide response. Another one was when the fires came and the work across the health authorities. I think it was just made that much easier by having a provincial forum. We developed a new guide called Welcome to Hemodialysis Unit, and I know old guides take a long time to die, and they still have lots of prints left, so they're slowly going out of print, and we're now moving towards a standardized booklet for orientation to a hemodialysis unit, which I think is a huge step. It took a lot to even agree on some of the nuances in the book, which again means we need to, those are places that we need to standardize so that we could then put it into print. So there was lots behind the scenes, but I think we should be pleased to say that we're probably the only province that has something like this. We have a nocturnal hemodialysis program implementation guide, and some of the newer programs have actually used the guide when they were starting their nocturnal programs. We've got several guidelines underway. I think the most, I think it was probably as challenging as the technical guidelines, maybe more challenging, was around the infection control, management of infection control issues. And we worked really hard to include our infection control colleagues in this work so that we hopefully can post the guideline and then it can go back. We talked about local implementation. We hope that will smooth the way for local implementation, because I think we've included pretty much everyone we could think of in terms of coming up with these recommendations. So I probably can stand here today and say MRSA and VRE, we are no longer doing routine screening every year for that for hemodialysis patients. And I think that's been one of those myths that's been around for a long, long time. Based on the evidence that we looked at and our own data, there was finally agreement to remove that as a standard screen. So you'll see, you can go through, and of course I've got cleaning and disinfecting HD machines on this slide, but you can go and look through the website and have a look at all of the work that's been done. I think the only other one I'll touch on is visiting patient guideline and tools, because I think that's an important one that we worked very hard on. We have a lot of movement of patients in and out of the in and out of BC in the hemo units, as well as within BC. So we did a standardized guideline, and all of our forms are now standardized. And we've been using it for about 2 years, and we're just about to launch a working group to actually review them and make some changes as we need to. But I think overall, it's been a huge improvement. So what's next? Fewer but larger initiatives. We're moving towards a more kind of initiatives that will have more significant impact. We're going to try and, as we mature in our evolution, focus more on the evaluation and supporting the implementation. So rather than generating a lot of new work, I think our focus over the next year or two is going to be sort of stabilizing the work we have and evaluating it. And we are going to work further on provincial quality hemodialysis indicators. We haven't gone as far as we would like to on that. Continuing to keep our tools up to date and looking at ways we can have more patient and family engagement in our work. So I think I'll stop there and thank everybody for their attention.